We'll talk about HIV AIDS today. It's an important topic, so we'll have to discuss it. And then hopefully subsequently we can start discussing the other topic or revising the other topics on emergency medicine. So of course, we would, as always, we'll look at some introduction. We would look at the viral features, the route of acquisition, which I'm sure we are all conversant with. Also the pathogenesis, clinical features, opportunistic infections, and the various clinical stages according to the World Health Organization. And also the investigations, how to confirm an HIV infection. Once the infection is present, what kind of investigations do you need to do as supportive investigations? And then we'll talk about management as well. So we are all aware of the disease HIV, and of course, we know that it's more of a pandemic because it's crossed borders of continents and it's associated with significant morbidity and mortality. Even though the number of deaths or HIV-related deaths have reduced slightly over the years, we still have rising incidents of new infections. Okay, so it tells us that, okay, well, we have developed new medications now, and these new medications that we have developed are basically helping with the disease condition and controlling the disease and preventing significant mortality and morbidity. However, in terms of, should I say, public health education or preventive measures and whatnot, we are failing and we are not doing enough. So even though the HIV AIDS related deaths are falling, we have new diagnoses also hitting up, because every now and then people are just doing what they aren't supposed to do when it comes to HIV AIDS. Okay. So in 2019, WHO statistics came out. We have over 78 million people who have become infected with HIV AIDS. 78 million, I mean, since they actually stated HIV AIDS as a pandemic, over 78 million people have been infected, and that's, quite a number. Okay, and over 33 million people have died from AIDS-related illnesses since the start of the HIV/AIDS pandemic. So, I mean, it tells us a lot. In 2019, over 690,000 people died. When you go on, you realize that, I mean, there are lots of statistics in terms of prevalence and whatnot, but all points to one direction, that it's still out there, even though people feel that it's far-fetched. And even health personnel feel that, oh, HIV/AIDS is far away from me and only some kind of people or some class of people can get it. We all have to erase such thoughts from our minds, because the disease condition that can basically affect anyone at all if you let your guard down or if you don't follow the proper protocol. So the disease basically is caused by a virus called HIV-1 or HIV-2, or in some cases, we've had patients coming in infected by the two types of HIV viruses, both HIV-1 and HIV-2. And we say that this HIV virus belongs to, or should I say this HIV or human immunovirus belongs to the Latency group of retrovirus family. So if you look at the virus itself, once you talk about retrovirus, then they have something peculiar as part of the enzyme, the viral structure. Okay, they have an enzyme called reverse transcriptase, and this reverse transcriptase, as we know, is essential in converting viral RNA to DNA. And once you're able to make this DNA, you are able to incorporate or integrate this DNA into the host's DNA. And that's why HIV is quite difficult to treat, because every now and then this reverse transcriptase enzyme is basically, converting viral RNA, transcribing it to DNA. Okay, ideally, it's the other way around. If you take the human protein synthesis machinery, we have transcription means that you are converting DNA into RNA, okay, through, a host of processes and whatnot. But this reverse transcriptase, as the name suggests, tells you that you're actually reversing that process of transcription. And so instead of the usual thing that humans do by making RNA from DNA, the virus is now converting its RNA to DNA, and it's going to integrate that DNA into the host's DNA. And once it does this, it becomes quite difficult. You have multiple sections of the host DNA becoming integrated, or you'd have at that multiple sessions where you have viral DNA embedded in the host DNA. Okay, so it makes it very difficult. It means that basically that host DNA would have to go off if you're actually trying to prevent anything from happening. You have to, you are not only targeting the viral DNA now, you're actually going to affect the host DNA. So it makes management or something like development of a vaccine very difficult, but people are working on it. This week, we've heard some good news about Moderna trying to make some HIV vaccines and preparing for trials. So we hope that they succeed, and then we can all take a shot and protect ourselves from this disease condition. If you take a look at the virus, you can see basically the structure. There's an outside structure, then you have an inner core. Okay, so the outside structure is made up of various glycoproteins, and this glycoproteins helps the virus bind to the host cell. And what is this cell that is binding to? It binds to the CD4 helper cells of the host. Okay, and this CD4 helper cells is needed by the host in, fighting infections, basically protecting the immune system. What the HIV virus does is that it binds to the CD4 helper cells, and then it basically destroys the CD4 helper cells, kills it, and reduces your CD4 helper cell number. And once your CD4 helper cell numbers drop, then you know that your immunity is basically dropping, because the cells responsible for being the soldiers are being attacked and being killed. So your system is now being left vulnerable to, should I say, the visitors who are not so nice, who are coming in to attack you. You can say the terrorist. Okay, so that's what the virus does. So you take a look at the virus, there's a glycoprotein, you have glycoprotein 120, glycoprotein 41, and this usually will bind to the CD4 helper cells. And then when you look at the inside of the virus, you can see the various structures of the virus that allows it to perform its functions. And it's these various structures that we've now developed medications against. You can see that you have what we call the reverse transcriptase, which is an enzyme that we've talked about. It's essential for converting viral mRNA to DNA. Transcriptase finishes its activity of transcription. It is integrated by this other enzyme called integrase. Okay, so you can see the integrase there as well. Okay, and then looking at the inner core itself, you can see the RNA of the virus. Okay, so you can see that. So thing is, if you want to manage HIV/AIDS as we go on, you see that we have different classes of medications. The best way now is to develop medications that will either inhibit this enzyme, this reverse transcriptase enzyme, or that would either inhibit this integrase enzyme, okay, or that would even prevent the HIV virus from binding to the cell at all, if possible. Okay, so as we go on, you realize that most of the classes of medications are based on specific parts of, this virus is based. They are based to prevent specific action of the viruses. Okay. So routes of acquisition, of course, we all know sexual intercourse, being it vaginal or anal intercourse, there's a risk of transmitting the disease. And usually if you have other STIs, especially STIs that are basically causing the breach in the mucosa, whether external mucosa or internal mucosa, the risk of you how should I say, acquiring the disease condition goes up. Okay, so if you have the inner aspect of the urethra, or basically the mucosal lining of the urethra becoming damaged because the patient has some form of gonococcal infection, this mucosal lining, which has become damaged, is exposed to the HIV virus. And once you have secretions getting in there, you are at risk of developing, your risk goes up in developing HIV/AIDS. Of course, if you have some disease condition like chancroid, or you have some syphilis, or probably some HSV, which has left an ulcer on the genital for a male, let's say the external genitalia, and you end up having sex with someone who has HIV/AIDS, then your chances of getting the HIV infection will go up, because there's an external breach in the, the epithelium. So once you are exposed, your chances of developing the condition will go up. Okay. There's also mother-to-child transmission. That's through transplacental process. If a mother is pregnant, then they can spread it to their child, or during the process of delivery, that's perinatal process. The whole process at that point, you can have HIV being transmitted from mother to child, and even breastfeeding as well. Blood transfusions, one of the ways of developing HIV/AIDS. And that's why I said the other time that you don't rush to transfuse unless there's really a need to transfuse. You need to be very, very careful. Organ donations and whatnot. Also, if you come into contact with infected needles, sharps, and all that, and you end up getting a cut or a prick, then you are at risk of developing the condition. So as I said, the virus has a reverse transcriptase. You can say converts viral RNA to DNA. Then there's a P24 core protein, which you can usually monitor these levels during HIV disease, okay? And there's a glycoprotein 120, which is the outer envelope glycoprotein, which binds to CD4 cells, glycoprotein 41, which influences the infectivity and then the ability for a cell fusion capacity. So it helps the virus bind with the cell and fuses with the cell, the ability of the virus to be able to fuse with the helper cells, the T helper cells, is basically dependent on the glycoprotein 41. So once you have the HIV binding to, the cell via the glycoprotein 120, there's an interaction, okay? And usually you need certain chemokine receptors called CCR5 and TXCR4. And this would have to come into play to enable the virus enter into the cell, okay? So the interaction between the CD4 receptor and then the HIV surface glycoprotein will lead to a process that is basically cytopathic, meaning that will lead to, a pathological process that would end up affecting the cell, okay? So this cytopathic process will lead to basically the destruction of the CD4 cells. So once you have an interaction between CD4 receptors and then the HIV surface glycoproteins, you know that you've signed a certain contract that may your cells be forever destroyed. Okay, so there's progressive and severe depletion of the CD4 helper lymphocyte, and this will lead to a reduced immune system and will basically expose the individual to a host of infection and then malignant tumors as well. So basically that's the pathogenesis. It's just a binding between the glycoproteins 120, which we talked about, glycoproteins 41, binds to the surface of the CD4 helper cells. And basically once this happens, there's an inflammatory reaction with syncytium formation, which is pathological to the CD4 cells and leads to destruction of the CD4 cells. Usually, after you become exposed, there's a silent period for about 2 to 4 weeks that you don't show any symptoms at all. And usually within these 2 to 4 weeks, if you do any serological tests, you don't pick up anything suggestive of HIV. But after this period, the person would start developing certain funny symptoms, like usually there are flu-like symptoms, some cold, some joint pain, some headaches here and there. And people call this serum sickness, okay? So this is when you seroconvert. At this point, it means that your system is now, you are now making antibodies against the HIV antigens that you have been exposed to. Okay, so it means you are basically seroconverting. And it's at this point that if we do most of the tests that looks out for antibodies, we are going to pick up antibodies because at this point you are basically seroconverting. So we call it seroconversion, or your serum is converting because you are making antibodies. Okay, so once you're getting that headaches, flu-like symptoms and whatnot, it doesn't happen to everybody, but in most cases, they tend to have it. Okay, sore throat, some lymph nodes here and there, some funny rash, then it tells you that there's some form of seroconversion going on. And after the seroconversion period, you basically look fine. You won't exhibit any symptoms at all. If you don't have a test done, you won't know that you are even sick at all. And this period is called clinical latency, and it can persist for so long. Some people can even get to about 12 years. And for some people who are not so lucky, it can just persist for about 3 to 5 years. It's variable. But for most people, say the average length of time for clinical latency is 10 years. Okay, but once you are in clinical latency, it doesn't mean the virus is sleeping. No, the virus is actually making more copies of itself to attack in your later years. Okay, so at clinical latency period, you are still replicating and you are basically looking fit because your immune system hasn't been breached totally yet. You still have some CD4 helper cells in action, but your CD4 helper cells, once the levels go down, and that would coincide with, the period where your clinical latency basically ends, you start developing the various conditions that we'll be talking about in a bit. In some small group of people, they tend to develop something we call persistent generalized lymphadenopathy, okay? So they tend to have lymph nodes that are not in the inguinal area. So they are extra inguinal lymph nodes. So they can have axillary lymph nodes, they can have epithelial lymph nodes, they can have cervical or submandibular lymph nodes. These lymph nodes shouldn't be painful, okay? And they should also be what? Symmetrical. So if you have some on the left, you should have some on the right for you to be able to qualify it as a persistent generalized lymphadenopathy, okay? And it should be more than 1 cm, okay? You should have it in 2 or more extra inguinal sites, and it should persist for more than 3 months. And usually once you see this kind of symmetrical non-tender lymphadenopathy, and you've done all investigations and you don't find any cause, and you've tested for HIV and it's positive, then we say that you have developed a persistent generalized lymphadenopathy. Evans, your hand was up. Hello, Evans. Okay. So.
Hello, sir.
Yes, hi.
Sir, please, during one of our community health class, the lecturer mentioned that there is a particular tribe in Africa who cannot be infected with the HIV virus. I want to find if it's true or it's a myth.
Well, I would have to find out. I've heard of people saying so many things, but as it stands now, I'm here to read any academic literature that specifies a particular tribe. They claim that the glycoprotein 120 and whatnot is not able to bind to the CD4 cells because their CD4 cells lack receptor cells for the glycoprotein 120 of the HIV. There are people like that. It's just a selected few people where, of course, just like the way you have mutations in people, there are people that possibly don't have receptor cells on their CD4, receptors on their CD4 cell to HIV AIDS virus. And in such people, clearly, of course, the HIV virus can bind. So it means that they can't get infected with HIV AIDS. But, the only way of knowing is, once you go, they do some tests for you and they say, oh, you don't have this, you don't have that. But would you want to risk that by saying, well, they said I don't have the receptor, so I can't have HIV AIDS, so I can do whatever I want. HIV AIDS is a very funny thing, so you cannot be too sure. But yeah, I mean, isolated cases, but I won't say that the whole tribe. I mean, I'm here to read something on that level. Okay, all right.
Thank you.
You're welcome.
Right, so my question, sorry.
Yeah,
my question.
Hello, yes, sir. Please. Yes, Ivan, I can hear you.
Yeah, at the stage where when you do the test and it's not showing, it doesn't show whether the person have the HIV. Maybe like you said, 2 to 4 weeks, I think. You said the person does not, when you do the test, the person it doesn't react. Okay. There's no reaction.
Yeah.
Yeah. So I want to know that period. Is that a period that they call the window period?
Yes, well, you can call it a window period. So and even that, when it comes to investigations, it depends on the kind of investigations that you are doing. We say that because usually the test that we do for HIV, we tend to look out for antibodies, okay? That is what the common test that we tend to do. That is the common test available in the health facilities when you come. Whatever test that we do, rapid response, all those things. first response, all those things, using the rapid test kits. We just want to see if your system has made antibodies to HIV antigen, right? So usually during that initial period where your system hasn't seroconverted, if we do those things, we won't find anything. And that is what people usually say, oh, that is the window period. So if most clinicians have HIV kits in their homes, and when they get some nice move in town, they'll take home and then they'll say, okay, let's have sex without condom, but I'll check if you have HIV first. And that whole thing about window period there is, what if the person just got the infection? It's just been 1 week, the person was exposed. It doesn't mean the person can transmit to you, because at that point, actually, there's something we call viral spikes, where the person is in the initial phases. So the person is actually making lots of viruses, just that the person hasn't started making antibodies yet. So your first response, your kits, your rapid test kit at home won't pick it up. Okay, so that period is like what we call a window period. The person hasn't seroconverted yet. However, because PCR looks for antigens, it looks for the presence of the virus itself. At that stage, if you do a test like PCR, which can detect the smallest DNA or RNA of whatever you are looking for, at that period, we say window period, a PCR can basically capture whatever you are looking for. Okay. So if you want to get a PCR machine to your home and you test everybody, fair enough. That one you be safe.
The
lab guys.
That one you be safe. Yes.
The
please.
lab guys.
Then it's possible that the lab guys, some of them are infected.
Same.
Yes. Hi. Evans, are you okay, please?
Is the lab guy.
Okay, let me take the last question and then we.
That's where my.
Sir, please, at that period, can the person infect another person?
Yes, please, the person can infect another person.
Oh.
Person can infect another person. Previous studies were suggesting that, in fact, the infection rate during the window period was so high than once they go past the window period, because usually during this stage, before they seroconvert, they are making high numbers of viruses there. We call them viral spikes. There are a lot of viruses being made, so the infection rate is even higher than the usual condition. But they've done further studies and they've realized that yes, even though you can infect, it wasn't so high as someone in that stage. Okay.
Why are the lab guys shifting in their seats like that?
And that is why window period. If you couldn't infect someone, nobody would care about window period. You can infect someone. Okay. Yeah, Evans, your hand is up. I'll take you.
Hey, again.
Yeah.
Only
Hey, the guys are free. Evans, are they? Wafa baby, Anna.
My second question is, I learned women has a higher, contracting the infection more than men. How true that is?
Yeah, well, it's just like most of the sexually transmitted infections that we talk about, like even what we're talking about the other time about the UTI and whatnot. The urinary tract infection also being common in women. The system of women tend to be more open as compared to a system of a male, which is relatively closed. I don't know if you get the idea. This is
no, sir.
We get it.
We get it.
I mean, this is this is in street man terms, I mean, exactly as you can see. So yes, and usually
compare.
Yes, please.
Compare this with the infection that you are saying. said, there's been so many cases that a woman or like couples will come to the hospital, sometimes antenatal, and the woman will be having the infection. The man will come in and the man will be negative. But looking at infection, normal UTI and others, you can have sex with a woman who is having something like UTI, and the next day the guy will be experiencing some funny kind of things. But here's the case.
Okay, it's not like that for HIV. So I don't know if you missed the other.
It's not like that.
Experience. Wow.
I don't know if you missed the other session. I said that urinary tract infections are not transmitted through sex. Okay, so I'm sure you are talking about STI, maybe some gonococcal or chlamydial infection.
STI.
Yes. So those ones. That's what I'm saying. When it comes to HIV, okay, the dynamics. Getting HIV AIDS, they'll tell you that getting HIV AIDS is not easy. You don't just get HIV AIDS. A lot of things would have to go on. Okay, there are people who have slept with people who have HIV AIDS, but I mean, the dynamics go in their favor and they don't get it. But if the same people go ahead and sleep with someone who has some gonococcal or chlamydial infection, 2 or 3 days after, they'll start having discharge. Okay. Sometimes you are looking at the infectivity. Sometimes you are looking at the infectivity of the pathogen in place. Okay. Looking at HIV, you can never tell when you get it if you are exposed to someone who has it. You can never be too sure. People have also had needle pricks from people who have HIV and they don't even get it. So that's the thing about HIV/AIDS. It doesn't mean that it's not very effective or it's not potent, but then there are a lot of dynamics at play. As we talked about, there should be binding and there should be some reaction after the binding, which would facilitate the virus entering into the CD4 cells. I mean, so a lot of things come to play. Okay. You have what we call the discordant couples, where you can have a female a couple come to you at the ANT, as you said. Female has, male doesn't have. It's possible that the female had before getting married to the male. You can never be too sure. Or it's possible that they both didn't have, but then the female passed somewhere when they got married. I mean, some of these things you can never be too sure. And they come with a lot of medical legal issues, whether you should tell the guy or not, but it's something that you need to discuss with the woman extensively, because the woman is the one with the disease condition, and try to convince her to divulge her status to the man. So you come across cases like that. Okay. The thing is that if you even think about the science behind it, most women are on the receiving end, and most women are more open. During sexual intercourse, you remember what we just said, that if you have STIs and whatnot, the spread of HIV/AIDS even goes up because of the breach in the mucosa. During sexual intercourse, where the man is inside the woman and just hitting and having fun, most women tend to develop cuts during this process. Women develop more cuts during the process of sexual intercourse than men do develop cuts. Okay. HIV virus is found in bodily secretions. You can have it in the semen. So if a man has HIV, it's easier for the man to transmit it to the female during sexual intercourse if there's no protection, because even during the process of sex, the friction and whatnot will lead to disruption of the mucosa that sometimes the female won't even feel during the process of sex. Will only feel after sex that, okay, I have some pain down there. And if by then the man has HIV/AIDS, has come inside the lady already, then it's easier for the virus to enter or penetrate the mucosa, because the mucosa has already been damaged. And that is why it tends to be more common in females. Okay. If a female has the condition and is having sex with the man, the dynamics will sometimes play in the favor of the man. The man would need to get a breach in the mucosa, which it's not so common as a woman developing a breach in the mucosa during sex. But if during this process, the man has some cuts due to some STI, some ulcer due to some STI, then it's easier for the man to get the disease from the woman. So you get the dynamics. This is, I mean, one of the main reasons why men are, men can easily give the disease condition to women. However, it's a little bit, difficult when it comes to the reverse of women giving it to men. Are you okay, Evans? I'm sure Evans is fine. I think there was one more question. Let me take it and then we go on because there's actually no time. I think someone also said they had a question. Okay. There's no question, then we go on. So clinical features, right? So as we said that we talked about initially, we said that symptomatic HIV infection develops over time. Okay, so as the infection progresses, the viral load would also would keep going up, and as the viral load keeps going up, it's basically eats your CD4 helper cells, so your CD4 count will fall. Okay, so basically that's the pathophysiology. Viral load going up means that your CD4 cells will fall. CD4 helper cells falling means that your immune system would reduce. You are going to develop immune dysfunction. And once your immune system starts going down, you are in trouble because you become at risk of one, pathogens that you will now be exposed to that your system would have been able to fight off. Now they become risk because your system is unable to fight them. Okay. And also the pathogens that you have experienced in your past life, even before developing the HIV AIDS. So let's say now almost all of us have been exposed to the TB bacilli one way or the other. So you have some TB bacilli nestling somewhere in your lungs, relaxing and chilling. But because your immune system is so strong, your immune system has sort of caged this TB bacilli. Once, as a patient, you develop HIV AIDS, and it means your immune system is going to fall. And this TB bacilli that has been dormant for years will now spring back to life, and you start developing symptoms of TB. Okay, so that's how it is. So it's not like in all cases of HIV AIDS who have TB, they got the HIV AIDS and they later got infected with the TB. No, the TB bacilli, most of the time, is just dormant because our environment, people are coughing here and there, especially those of us in hospital environments. It's everywhere. We've been exposed one way or the other. But once your immune system is up or is intact, you know that you are not going to show any symptoms of TB. Once the immune system falls, then you are in trouble. The TB bacilli can spring back to life and start giving you problems. So, of course, usually when your CD4 count falls more than 100 mm cubed, then you are, the risk of developing these conditions go up. This is when we say that indeed they are really immunosuppressed. So there are some examples of disease conditions that you can develop and based on systems. So once you get the slides, you try and go through. So with the central nervous system, you can have AIDS dementia complex, you can have sensory polyneuropathy, aseptic meningitis, autonomic neuropathy, cerebral toxoplasmosis, where you are basically exposed to the protozoan called Toxoplasma gondii, and this Toxoplasma gondii will basically be in the brain and cause issues. If you do a CT scan, you usually find what we call a ring-enhancing lesion sitting there in the brain. Okay. Remember, I think I've given your senior colleagues a past question on HIV/AIDS, where the man had a sudden collapse and did a CT scan, and they found a ring-enhancing lesion in the brain and all that. So that's cerebral toxoplasmosis for you. You can have eye diseases where you have inflammation of the retina from cytomegalovirus, and that's CMV. You can have pneumocystis, you can have toxoplasma of the eye, syphilis of the eye, you can have lymphomas when you're looking at hematological conditions. So non-Hodgkin lymphomas, you can have anemia, neutropenia, thrombocytopenia. Basically, your cell lines can just drop, which we call pancytopenia, when it happens to all the cell lines. You can have chronic diarrheas, weight loss, your acidity in the GI would reduce, so there's a gastrointestinal effect. Your kidneys can fail, what we call HIV-associated nephropathy. You can develop chronic sinusitis when you're looking at the respiratory system. You can have lymphoid interstitial pneumonitis. You can have pneumocystis carinii and pneumocystis jirovecii. All these are types of pneumonia you can get from HIV. Endocrine, your testosterone can drop, your adrenaline function can become impaired. Cardiovascular, you can develop cardiomyopathy secondary to HIV. You can have inflammation of the myocardium secondary to HIV as well. Then, of course, mucocutaneous manifestations, these are common, where the rash and whatever comes in. So herpes zoster caused by varicella zoster, which would usually give you a dermatonal rash. You can have your warts because of HPV infection, you can have folliculitis, you can have pityriasis, you can have tinea, molluscum contagiosum, all these conditions. You can have recurrent candida infection. This time around, it won't just be candida in the genital region. You can have candida of the mouth, oral thrush. You can go all the way to the esophagus. Sometimes you can even have candida in your bronchial system, okay? Also, you can have oral hairy leukoplakia. So there are a host of disease conditions that you can develop. So opportunistic infections, we say they are caused by organisms that would usually not be considered pathogenic, because your system will be able to fight it and it wouldn't even give you any clinical features at all. Okay. And usually you are looking at very funny organisms and very funny, tumors of viral origin. Okay. So in terms of HIV, I mean, I've given you a table here. So the protozoans, you can see Toxoplasma gondii, which causes cerebral toxoplasmosis. Cryptosporangium parvum and Isospora belli causes chronic diarrhea. Okay, and there's leishmaniasis also over there. Viruses, you can have cytomegalovirus, herpes simplex, varicella zoster, which causes herpes zoster. Human papillomavirus, of course, which will cause cervical cancer. So patients who come in with cervical cancer, we also do a retro screen for them, just to be sure the cervical cancer is not because their immune system has dropped. Okay. Then, of course, your fungi, where you have pneumocystis jirovecii, you have Cryptococcus neoformans, which can also cause some form of meningitis. You have Candida, aspergillosis, histoplasma, and all that. Bacteria, you have Salmonella, you have TB, you have strep pneumoniae, you have Haemophilus influenzae, all of these things. Of course, your system should ideally be able to fight them, but then once your immune system is dropping, then there's a risk of developing this opportunistic infections. So the WHO has 4 clinical stages, stage 1, 2, 3, and 4, where stage 1, basically, patients shows no symptoms at all, or would have what we call persistent generalized lymphadenopathy, which we've talked about. Stage 2, they usually have an unexplained weight loss of less than 10% of total body weight, okay? And then they have some recurrent respiratory tract infections like bronchitis, otitis media, sinusitis, pharyngitis. They can have some skin conditions like herpes zoster. So this will appear as a dermatonal rash. They can have papular pruritic eruption. So they come and then you see this black spots, which is very, very itchy on their skin, okay? So stage 2, basically we are looking at dermatology and some respiratory system. And then stage 3, they lose weight, but then the weight becomes more than 10% of the total body weight. Remember, stage 2 is less than 10%. Stage 3 becomes more than 10%. They have chronic diarrhea. Then they have severe respiratory tract infections, not just sinusitis and bronchitis. This time they are having the TBs, they're having the pus in the lungs, so the empyemas, the lung abscess, and whatnot. They can have meningitis as well. Then they have the oral hairy leukoplakia, recurrent oral candidiasis. All this will be in stage 3. Okay. Then stage 4 is when they have severe symptoms. Stage 4 is when we say they have AIDS defining illness. Okay. So stage 4, they can have candidiasis. This time, not just any candidiasis, esophageal candidiasis, tracheal, bronchial, can have candidiasis in serious places. Okay. And they can have meningitis, so how do you call the cryptococcus that we talked about, cryptococcus neoformans, can have cryptosporidiosis for a very long time. Then they have the lymphomas as well. The histoplasmas will also come in, the toxoplasmas will come in. Okay, so stage 4, we say that they have HIV AIDS defining illness. Okay. So how do we diagnose? Of course, we can do our PCR if you think you've just been exposed just a couple of days and whatnot. Then probably you're in the window period or whatnot. You want to try and see if the virus is present, is replicating. Your PCR is that good, that it will pick up early, very early conditions. Okay, and then of course you can do detection of the IgG antibody by doing ELISA. You can do confirmation with a Western blot assay. You can also detect the IgG antibody to P24, okay, as we've talked about. You can use your PCR to detect the P24 antigen shortly after an infection, okay. Then you can also isolate the virus in culture. So those are your diagnostic tests. Your supportive tests, of course, you'd want to do a full blood count, inquiry, liver function test, lipid profile, fasting blood sugar. This is essential because you want to know your patient's state, and this will help you because most of the medications have issues with kidneys, livers, and whatnot. And most of these medications will be excreted by your kidneys or your livers and all function properly before you start any form of treatment. CD4 cell count is essential. It tells you where you are starting with, okay? So that once you manage, you can keep monitoring your CD4 to know whether you are winning the battle or you are not. Then you can do a viral load, and you can do an HIV genotype if you want to know the type. And then Hep B, Hep C is very essential. You need to do all that. You need to do a chest x-ray because you want to be sure your patient doesn't have TB. Chest x-ray would help you show you some features. Okay, you can check for syphilis, cytomegalovirus, toxoplasma, all of this. You can look out for their IgG. Okay. I think someone's hand was up. I think I saw counselor's hand up. Yes, please.
I want to ask, like, after the exposure, around which period does post-exposure prophylaxis work? Like after you are being exposed to the virus?
Okay, so when you have been exposed to the virus, which we'll be coming to in a bit, you would have to start your post-exposure prophylaxis within 72 hours of exposure. That is where research has shown that it is more accurate in working. Once you go beyond 72 hours after exposure, your post-exposure prophylaxis may not work. Okay, so if you need to start your post-exposure prophylaxis, it has to be within 72 hours of your exposure.
Okay, thank you.
You're welcome. I think there's another hand up. Sylvanus? Okay, we'll go on. We'll wait for Sylvanus to come.
Sir, good evening. Sir, good
yes,
evening.
Sylvanus. Yes, good evening.
No, this is not Sylvanus. This is O'Neill.
Yes, O'Neill.
Yes, sir. If I understand it very well, that means, hello.
Yeah, O'Neill.
Hello.
Yeah,
yes,
O'Neill, we can hear you.
So if I understand it very well, that means most of the treatment depends on your immune system, how strong your immune system is. If the immune system is strong, that means the viruses cannot even bind to the receptors for them to replicate, right?
Oh, not at all. The virus is there once they enter your system and you have receptors on your CD4 cells for them, whether your immune system is strong or not, they will bind. The strength of your immune system comes in when you are looking at when you start showing clinical symptoms. And the strength of your immune system is dependent on the number of CD4 cells that you have. So you can be the fittest person with very high numbers of CD4 cells, but if the virus goes in and is able to bind, which is usually the case, it will start destroying your CD4 cells. The advantage that this person has over someone with a weakened immune system is that the person with a weakened immune system might start showing clinical features within just 2 or 3 years. But eventually, the person with a strong immune system would show clinical features, averagely 10 years. The only thing that would save this person is during that time, the person is not showing clinical features. Maybe the person walks into a healthcare center to do some HIV test routine, and then they pick it up, confirm HIV positive. Okay, let's quickly start ARVs. That's the only time this person won't show clinical features, because the ARVs will come in and will stop the viruses from replicating further. And once the viruses don't replicate further, your body will now make more CD4 cells. You get it? So it means you won't show any, form of symptoms at all, and you'll be fine throughout. That's if you don't stop taking your medication. So that is what is dependent on. It's not just the immune system, because immune system would eventually fall if the patient is exposed to the HIV virus, unless there's medication. Okay.
Okay, sir, thank you.
You're welcome, O'Neill.
Yeah, sir.
Yes.
Sir.
Hi.
About the investigation.
Yes.
And now we have after the first response, then we have the oral quick. We have a third one we have a third one now that we use to confirm it. As in making 3 now, we call it SD bioline. So the protocol is now saying that 3 must be positive before you start treatment. So that is about the investigation.
Yes. So it's just for confirmation, just so that you don't get what's that even called? You don't get a false positive results. But if you get your first response being positive, and you go ahead and you do oral quick and it's positive, do you guys still add the third one?
Yes.
All right. Okay.
So you have cases where first response is positive, oral quick is positive, and SD bioline is negative. So that one we don't treat. We give time and we repeat.
And then
so
you retest again.
Yes. So now the protocol is saying all the 3 must be positive before you initiate treatment.
I see. Okay. I think I have a slide on that, which is not part of this. I would see if I can send you guys a screenshot. I got to know during a recent HIV training that they are now doing, as you're saying, they are now doing basically the 3 tests just to be sure.
So does it mean that the oral quick is not potent anymore?
Oh, it's not about that. But you see, the thing about HIV is as you go on, a lot of things happen. I mean, when you have an organism in the system for a very long time, mutations happen to the organism. Your body also starts adapting in a very funny way. And there's been a number of cases where they do a first response, which comes back positive. And then later they go and do it and it's negative and whatnot. So they just want to be sure. And that's why they brought that whole triple thing in there, just so that you can satisfy whatever is recommended before they put you on ARVs. Because trust me, you don't want to start ARVs if you are wrongfully diagnosed as HIV. The side effects and whatnot, it's not fun at all. So, I mean, that's where the whole testing thing comes in place. I'll try and send you guys a screenshot on your WhatsApp page. Okay.
Okay, sir.
So there's like a flow chart. So you basically screen with first response. If the first response is non-reactive, you just report as HIV negative. However, if your first response is reactive, then you go ahead to test with OraQuick. When you do your test for OraQuick and then it's reactive, so you have first response reactive, OraQuick reactive, then you go ahead and then you confirm with the SD violin. If you do it and then your first response was basically reactive, but your OraQuick is non-reactive, you are going to repeat both your first response and then your OraQuick. Okay. So if you go ahead and then you are confirming with the SD violin in a patient who has both first response reactive and OraQuick reactive, you do the confirmation with SD violin. If it's reactive to first response, OraQuick, and SD violin, that's all the three tests are positive, then you go ahead and report as HIV positive. Okay. If your first response was reactive, OraQuick was reactive, but SD violin says that your result is negative or non-reactive, then you go ahead and you say the HIV result was inconclusive. So you need to retest in 14 days. Okay, I'll try and send you that full chat. But trust me, most of the time, if HIV 1 or 2 first response is positive, for me, when I was in private practice, I know this is not so common with the government sector because most patients are on government insurances and whatnot, they wouldn't pay for it. But if your patient is on a private insurance provider that is going to pay for some expensive labs, or you have the patient has cash, then you do your HIV first response is positive. To just cut everything short, if you don't want to go through all the stress, I request for them to go and do a PCR. HIV, I specifically state that Lancet should do a PCR for them. Okay, so they will take the sample and run a PCR. If the virus is there, PCR won't miss it. So that one, you wouldn't have to go through your OraQuick and SD violin. But of course, to save cost, and this is the standard now, what you need to know, you just need to go it. Okay, so thanks a lot. Was it Silvanos who made the input?
Hello, sir.
Yeah.
What about
so with the one you are saying to the government side, we have the
yeah, Fred.
Yeah, please, I just want to add to the answer you gave to the One question.
Yeah.
The thing about when you are, you see, the drugs are for the replicating, the viral replicating stages. So in case, if you target the stages, and you are able to knock some stages out, then the immune system can survive. Then when the immune system is boosted up, it can fight the opportunistic the opportunistic diseases that come. So the immune system will not directly be fighting the HIV virus, but it will be fighting the opportunistic diseases that come with it. So when
that makes sense too in a way. But if, as you're saying, you take the medication and then is able to hit the virus in certain areas, and then there's no replication of the virus, your chances of getting opportunistic infection is low. Opportunistic infection will only come in when the virus succeeds in defeating your CD4 cells. That is when your immune system will go down. But if you are taking your medication, most likely your immune system won't even go down for you to develop opportunistic infections.
Yes, but sir, you know the reservoir, the virus has a reservoir that you can't wipe away the reservoir. The provirus, the DNA, the provirus is always there. So when you take the medication and you're able to knock out certain replicating stages, the immune system, that's where the CD4 count will start going up. So when it drops, that's where the CD4 count will start shooting up. So therefore, you can't wipe away because there's a reservoir there.
Of course, clearly, you can't get zero, but then you can get a viral load that is basically undetectable when your patient goes on the ARVs, and that doesn't mean you should stop. So as you are saying, it doesn't leave totally. If it leaves totally, then once you get undetectable viral loads, everybody will stop taking the ARV. But because there's still something there that will never go away, you can't stop taking your ARVs. You get it?
Sure.
Yes. Clearly, of course, when you take it, you will be able to hit it and your viral load will drop to zero. And that is why this, I don't want to mention any names, but these people on TV now who initially tested HIV positive and now are coming back and they are saying, oh no, it was just for the adverts. They are HIV negative. I'm sure we all follow the story. And then they said, all right, okay, let's come to live TV and let's test. They did a test and then basically it was positive. And some people will say that, oh, maybe she has a psychological problem or not. Maybe she does, but maybe she doesn't. Maybe she took the medications judiciously in the initial stage. I've seen people take the medications so much that when they come and then you decide to test for HIV, you won't get them to be HIV positive. You might be confused. You understand?
Okay.
So the medication is that good that it can actually make your viral load basically undetectable. But as you said, it doesn't mean it's zero. There's always something there. There's always a parent something there. So when you stop, the replication will start again. And this time around, when we test, it will be positive. So it's possible that she stopped because she thought that now she's fine. And when she decided that we should all check, we checked and then it was positive. Okay.
Okay. Got it. Thank you, sir.
You're welcome. So let's quickly go on. Time is fast spent. So the management, basically, in terms of HIV, we want to treat the HIV disease. That's one. And then we are looking at treating opportunistic infections as well. Okay. And then, of course, we look at preventing HIV where we have, for now, we don't have a vaccine. We are hoping Moderna will be successful because the HIV is really worrying boys, and girls. So we are just hoping that Moderna will be successful and come up with a vaccine so that people can have free range and have fun. But that means that we'll now start looking at managing other diseases. If we don't get anything worse than HIV, at least we'll go back to managing a good old gonorrhea and syphilis and whatnot. But anyways, we wish the scientific community all the best. Once they are successful, it's for all of us to enjoy. So let's just hope things go well. Okay, sorry about that. So let's look at the classes of medications that you can have. So in terms of the antiretroviral drugs, as I said, the medications are made to attack certain. Okay, so you can have medication made to affect the reverse transcriptase enzyme. You can have medication made to affect the protease enzyme that we talked about, which is essential in cleaving and helping the whole viral replication process to go on. Then we can have the ones that will affect the fusion, okay? Then, of course, remember we said that when they bind, you have co-receptors CCR5 coming in place, CCXR4 coming in place. You have medications that can block this co-receptor activity as well. Then you have the medication that can inhibit this enzyme integrase. So it will prevent after the whole reverse transcription activity has gone on, if you are on this medication is going to prevent the RNA that has been converted to DNA by the virus. It will prevent it from integrating into the host DNA. So it's actually a game changer for us now. Okay. So in managing HIV/AIDS, there's something we call HAT, okay? And basically what we want to do is we want to do a highly active antiretroviral therapy. And this means that we can't just manage HIV/AIDS with one medication. If you manage HIV/AIDS with one medication, then what happened to chloroquine will happen to all our HIV medication. The virus will basically develop a resistance to the medication, okay? Very, very fast, and the medications won't work. And these medications are expensive. Lots of scientific work has gone into make this medication. So you can't just put the patient on one for the patient to develop resistance and then it becomes waste. Okay, so we do a combination therapy, and usually we tend to combine. There's a class where we call the nucleoside reverse transcriptase inhibitors, or we have a nucleotide reverse transcriptase inhibitor. Okay, so I mean the nucleoside and then the nucleotide reverse transcriptase inhibitor, they do the same thing, right? The only difference here has to do with when you look at the structure, the backbone and whatnot. So if you remember your phosphate sugar backbone, your nucleotide, all those pentose sugar and all those things, that's where the difference lies. But then they basically do the same thing. Among the nucleoside reverse transcriptase inhibitors, you have drugs like lamivudine, zidovudine, stavudine, and tricetabine, and dinosine. And then the nucleotide reverse transcriptase inhibitor, that's where you have your tenofovir. I expect that once you get the slides, you try and go through, and then you know the side effect that comes with the medication. Then you have the non-nucleoside reverse transcriptase inhibitors. This medications also affect the reverse transcriptase enzymes. However, they are non-nucleoside in structure. Okay, so you can take a look at that as well. Then you have your protease inhibitors like the lopinavir, ritonavir, and all that. And this will basically, as the name suggests, inhibit the aspartyl protease enzyme of HIV. And so once it does that, the whole process of making lots of cells would be stopped, basically. Then you have your fusion inhibitors, so subcut and enfuvirtide, one of the main medications. That's not so common here in our environment. The same for the co-receptor blockers like the maraviroc, which is also not so common. Now the integrase inhibitors, the new or the current standard now makes use of integrase inhibitors. As I said, it prevents the integration of the viral DNA into the host DNA. So these are common combinations. Currently, I mean, the recent standard now is that we are trying as much as possible to switch all our patients who are on the old standard, which was tenofovir lamivudine efavirenz, to tenofovir lamivudine dolutegravir. Okay, so now we are doing more of TLD. Initially, we were doing more of TLE. Now we are trying to switch patients to TLD. Okay, even if your patient is on, let's say, you are looking at tenofovir, lamivudine, and nevirapine or something, you need to switch the patients because now there's some sort of shortage with nevirapine. So even if your patient is doing well on that, you need to counsel your patient and then switch. Okay, about dolutegravir, unlike the other previous combination that we had, for instance, if you take something like this combination of tenofovir lamivudine efavirenz, which looks at, you need a backbone, as I said, of 2 nucleoside or nucleotide reverse transcriptase inhibitors or something like this, okay, plus 1 non-nucleoside reverse transcriptase inhibitor. Okay, usually that's the backbone that you need for your highly active antiretroviral drug. So this basically satisfies that. But then we realized that if you are doing this, your HIV-2, usually, if you go back and then you look at your non-nucleoside reverse transcriptase inhibitors like efavirenz, nevirapine, they are ineffective against HIV-2. Okay, so that's why the HIV genetic sequence is important. Once you know the genotype you are dealing with, if it's HIV-2, you know that if you are doing tenofovir lamivudine efavirenz, it won't work. Okay, because this efavirenz is a non-nucleoside reverse transcriptase inhibitor. So usually for HIV-2, we do a backbone of 2 nucleoside or nucleotide reverse transcriptase inhibitor plus a protease inhibitor, the lopinavir, ritonavir, and all of that. The good news, however, is that this new combination of lamivudine, tenofovir, and dolutegravir can be used for both HIV-1 and HIV-2. Okay, so the dolutegravir can be used for both HIV-1 and HIV-2. It also has relatively lesser side effects. Patients are able to tolerate dolutegravir better than the other previous medications, and it's able to bring the viral load down faster than the other one. So this is the current one, right, that we are looking at. However, there are other combinations. Maybe with time, you might not get dolutegravir on the market. We can go back to our old TLE combination or TEE combination. Okay, so this is a nucleotide reverse transcriptase inhibitor, is a nucleoside reverse transcriptase inhibitor, and it's a non-nucleoside reverse transcriptase inhibitor. For HIV-2, as I said, we are now using this because it looks at both HIV-1 or HIV-2, but if this is absent, then you don't need to put your patient on a non-nucleoside reverse transcriptase inhibitor. It won't work. You give this and then a protease inhibitor or even an integrase inhibitor. Okay. Your opportunistic infections, we would usually want to manage them based on the infection that comes up. There are various medications that you can use. For instance, if your patient has herpes zoster or shingles from varicella zoster, then you know you are giving your antiviral medications like acyclovir and all that. Okay, if your patient has a toxoplasma, you know that you are going to give your antiprotozoan medication and all that. So your opportunistic infection, you manage them according to the organism that is causing. If you have HIV and TB, then you know you have to start your anti-cock medications for your patient, okay? But to prevent opportunistic infections, you can do a prophylaxis of septrin, okay? Sulfamethoxazole and trimethoprim. You put your patient on that daily. In the course of your treatment, if they develop opportunistic infections, then you can go ahead and do a twice daily dose for the patients. If the opportunistic infection is that severe and is affecting major systems like the central nervous system, then you can actually double the 960 and do a double 960 dose in the morning. That would be like, I think, 1,820 morning, 1,820 evening. Okay, so basically that's how you go about it. You can just do a prophylaxis of 960 mg daily. If there's a disease condition, you can do 960 milligram BD. If there's a very severe opportunistic disease condition, you can do 1,820 BD of your septrin for the patient. Okay. Post-exposure prophylaxis, as we said, you need to start within 72 hours of exposure. Beyond that, it might not work. Within that, it's likely to work, but it doesn't mean that 100% it will work. That's what we should understand, that if you are exposed to HIV virus and you run and take your post-exposure within 72 hours, it means that it would work 100%. No. It gives you a higher chance of you not developing HIV, but it's not 100%. You need to continue for 28 days when you start. The preferred regimen, tenofovir, emtricitabine, and raltegravir. The combination of tenofovir and emtricitabine is called, the trade name is Travada. And now when you go outside, they've actually licensed this and people are using it for pre-exposure prophylaxis. So for people who are at high risk of developing HIV, the men sleeping with men, the commercial sex workers, all these people are at a higher risk than the general population. So they take a daily dose of tenofovir and emtricitabine to prevent the disease condition. Okay, so it's been approved in other countries. So I think we'll take questions, and it's actually a big topic, and then we make sure we go through when we have time. So Vanos, your hand is up. So let's take your question.
Say about the dolutegravir. Now we are using it in general, but we don't give it to the pregnant women. So currently, the pregnant women are still on the efavirenz-based combination.
Yeah. Okay.
And for the post-exposure, for that one too, in the case where we don't have that combination, we can go for the tenofovir lamivudine
combination.
Yes, and we add lopinavir potentiated with ritonavir. That one too comes as a combination as an option if you don't have the emtricitabine base.
Okay. That's great. I'm sure so I'm sure that's the reason. That's great. Thank you.
Hello, sir.
Hello, sir.
Hello, sir.
Yes.
My network wasn't good. Then I didn't hear, maybe you've said it, but I didn't hear. What's the difference between the type 1 and 2, the virus?
Oh, well, do we say they are any difference? It's basically the same. You can just say they are identical twins, but just like twins, you still have some main differences when it comes to genetics. So the main thing is they will still basically leave the host with the same clinical features if they are not managed properly. Okay. The main reason why we need to know them is that some of the medications are ineffective against the type 2. So you just need to know what you are handling so that you know what you are giving. But basically it would end up giving you the same condition. And some people would say that the type 1 will give you a severer condition than the type 2 or whatnot. But basically in the end, you end up developing the same clinical features if you are not managing properly. Okay.
Thank you.
All right, sure. Yeah, so Amos.
And if the 1 and 2, we have cases where the client will have type 1 and type 2. In the past, when we're using the efavirenz based, they have to add lopinavir R. But now that we have the dolutegravir based, it's work for both type 1 and 2 or single type 1 and type 2. So if the patient have both type 1 and 2, the same dolutegravir base will work. And if you have only type 2, that same base will work.
Yeah. So as stated in the presentation, so that's the advantage with the dolutegravir now. That, as I said, it will cover both your type 1 and type 2. And that's why we are actually switching from the other one to this if we have. Yes, please. I think there's someone else wants to ask a question. Yes, please.
Okay, sir, please, about the dosage, you've not spoken about it, but I want to know a person that has almost like the viral load count is so low, would the person still be taking the same dosage as before? And then a person who defaults to, how does he also take the medication?
You said if the viral load is very low, will the person take the same dose of medication?
Yes, the viral load is almost undetectable. Like, will the person still take the same dosage as before, as he started? Or how does that also work? And then somebody who defaults.
Okay, all right, okay. I get what you mean. So you want to say that when you start managing your patient and then your patient is getting better, do you reduce your dose?
Yes, please.
No, you don't reduce your dose, please. Why would you want to change a winning formula?
Okay, because I saw there are side effects to it. I saw clotting factors, fat metabolism, and then sugar. There are side effects with that. So I want to know how you would go about it, or you just
So that's the issue with your ARVs, and just like you putting patients on any medication for a chronic condition, there are side effects, and that's why your patients needs to come for regular reviews so that you'll be able to, one, not only monitor viral load, but also, as I said, as part of your supportive investigations, you are doing your LFTs, your lipid profile, you are doing your kidney function test. You want to know what is happening. If you look at the medications and you get the side effects, and probably your patient is developing any on, then you would have to adjust your medication. Some of them have fixed doses, whilst others are also based on surface area calculations. So maybe that is where your dose might change if your total body surface area, has changed in a way. But if not, you wouldn't want to do that. All right.
So please, and I want to know for children with HIV, what do they also go about the same way with the dosing, the medicines they take?
That one, the pediatrics will sort you out. But yeah, some of the, looking at some of the medications, the dose is basically similar to adults regimen. But as I said, if you are using surface area and whatnot to calculate, then clearly your dosing would have to go down when you are dealing with children. Even with your prophylaxis for septrin, it would have to go down. For instance, one medication that you might have both adults and children taking the same. If we are looking at this new dolutegravir, for instance, where we expect that adults are taking about 50 milligrams once a day. If you have children who are also about 20 kg and above, there's also a tablet of 50 milligrams once a day for children. But if you are calculating with surface area and whatnot for other medications, then clearly the dosing of one person will be different from the other in a way, or adult dosing will be different from pediatric dosing.
Okay, thank you.
All right.
Sir,
Yes.
Good evening, sir.
Yeah, good evening.
Yes, sir. The incubation period is the 2 weeks to 4 weeks. Is it the same for everyone or it differs? And the second one is when do we say someone has the HIV, and when do we say that person also has the AIDS? Because I overheard that HIV leads to fully blown AIDS. How true is that?
Yes, all right, okay, you're welcome. So the incubation period, that's why it's a range, so it varies, okay. Sometimes you can even have some literature saying about 2 to 6 weeks of window period. So it varies. It's not fixed that everybody will get 2 weeks, everybody will get 3 weeks. Okay, so it actually varies. And then, of course, HIV is what you get when you are exposed to the virus. And we do the test and then it comes back positive. Then we say you have HIV. AIDS comes in when you get to stage 4. And that's why, per our discussion, after our clinical stage 3, we went to stage 4 and we said stage 4, there's a severe symptomatic stage. And this is a designation that includes what we call the AIDS defining illness. So if your patient hasn't gotten to the AIDS defining illness stage, like as listed here, okay, as listed here, you don't say your patient has AIDS. Okay.
Okay.
You get it? Yeah.
Okay, sir. Okay. Thank you, sir.
You're welcome.
So there's a question in the comment section.
Okay, let's see. So what happens if there's drug failure or resistance to the dolutegravir combination against HIV 1 and 2? What is the next option, as we do have in the first, second, and third line of treatment? So wants to know if it fails or if there's resistance. And because it's something new now, it will be very rare for us to have resistance now. Okay, but if we are hard pressed with situations where we need to use something else apart from the TLD, we of course can go ahead and do our TLE, which is the tenofovir lamivudine efavirenz based. Okay, that is if we have to basically decide not to go according to our TLD, which is a new protocol. We can go back and then we start. So if you look at the new guidance for new clients, it will tell you that go ahead and then you start with TLD now, which is tenofovir lamivudine dolutegravir. However, you have to start tenofovir lamivudine efavirenz if there's contraindication to TLD, which is the tenofovir lamivudine dolutegravir. Or if your client goes like, oh, this is new, taking it, you don't have to refuse the patient. You can go ahead and give tenofovir lamivudine efavirenz. Okay. Are we okay, please?
Yes.
So good evening.
Okay, great. Good evening.
Yes, talking about prophylactin, in this our field of work, let's say you got exposed to the virus and the duration is 72 hours and it's past 72 hours before you were able to, before a drug was given to you, a prophylactin was given to you. In this case, what do you do extra to prevent yourself from not really getting it? Is there anything you do extra, or you just have to take the prophylactin since it's even past the 72 hours? of exposure in this our field of work?
Yeah. So as you said, if you should find yourself in that circumstances, which you shouldn't find yourself in that circumstance, because even if your public health department doesn't work on weekends and you develop the prick on Friday, we will tell you that wait until Monday and you start. That is like 72 hours. So wait until Monday and start. Okay. If it so happens that you go beyond that, there's nothing more you can do. You just need to take it and just pray that at the end of your 28 days, if we test you, you should be negative. If we repeat the test again in 3 months, you should be negative. If we repeat it in 6 months, you should be negative. Really. You can't do much than just to take it and just
pray.
Yeah.
Okay.
Yeah. But it shouldn't happen. The reason why I'm saying it shouldn't happen is most of the time, we clinicians, we get needle stick and we are scared, or we think that if you go and tell someone, it becomes something else. We are supposed to be the first line people stomping out, how do you call it? Stigmatization. So if you feel you've been pricked, if you are not sure, just go to the public health unit. They'll keep it quiet and you start your ARVs. If you are damn sure you are pricked, go and then get it started. If it happens on weekends, wait. If you can get them to come on a Saturday or a Sunday, that's excellent. If not, Monday, that is 72 hours for you. You get it done and you should be okay.
Okay, sir. Thank you.
Hello, sir.
I think we can close for the day. Leave all the rest.
Okay. I think that's the last question. Yes, please.
For the exposure prophylaxis, that is what we refer to as HIV emergency. So the protocol is if the health worker should get a prick, even if it is 2 a.m. midnight, you call the ART staff or the pharmacist for a drug. So in the case where the injury happened on Saturday, the earlier the better.
Yeah.
So that one means you call the pharmacist or the ART
they
staff,
should come.
They should be there.
Ideally, you know.
Sir,
ideally,
I want to ask him where he works. Like where does he work?
Ideally, it's supposed to be so. But you know why? You know why I chipped in that Monday? Because even during the HIV training, where they should be promoting what Sylvanos just said, that if it should happen, then you should contact an emergency. The answer was that if you should get a prick on Friday, you can wait till Monday because it's 72 hours, which, of course, once we are all clinicians, you can't, you know how the psychology of the whole thing is. You are going to sleep on Friday, Saturday, Sunday. By Monday, you would have lost that 10% of weight that HIV stage 3 is talking about. So ideally, Sylvanos, you are right. Ideally, they should come. But if they don't come, you can't do anything about it because they will tell you that it's 72 hours. So you can't do much. But ideally, I mean, the services should be provided. The thing is that,
I wanted to ask whether Sylvanos, where does he work? Does he work in a hospital or a CHIP compound, a polyclinic, or what? I think what he's saying is it doesn't apply in a CHIP compound.
No. In a CHIP compound, you fall under a district. At our Volta region where I work, needle prick is an HIV emergency. Even my boss at the region, but you call him midnight.
Which part of Volta region are you?
Akachi.
Which part of what?
No, see, it's good. That is good practice. You see, no, that is good practice. So when we all, achieve that position, and then you are in charge, you should be able to respond when you are called. But it's not always the situation. And people will always say, yes, I understand. And people will always say that, oh, So keep some of the HIV medications or whatever, the prophylaxis on the ward so that people can take. But you see, because of our own stubbornness and dark arts and dark mind, so they can't keep it on the ward.
That
You
one
see,
they will never do.
every now and then I get people calling me. They call me, they tell me that Charlie Doc, yes, Steve Becker, or I miss some babe, wait, Charlie. It's in hopping. So they call me every now and then. So they want to know if I can get HIV because as soon as it happens, when it's going to happen, they don't read about it. But as soon as it happens, then they'll take the phone and they'll read, and then they'll see that, oh, you can actually take a drug within this thing. If you are, Google will give you nice information. So then they'll call you and they'll tell you that they want HIV prophylaxis because they slept with someone they think has HIV. Not that the person has HIV, or they think the person has HIV. You see, and it can be challenging. So if you have a healthcare professional who is also in that line of business, then you know that every Monday, by the time you come, the prophylaxis is finished. Like, it's finished because every Monday, every Friday is game night. So they'll even take the prophylaxis before the action in the night just to prevent it. So
the medicine is going to wait for the bacteria.
It's going to wait, just wait for the virus to come in. So those are the issues. I mean, I'm just hoping that we would, if the vaccine thing works, then we are lucky. If not, the time is going to come where we will fully accept the pre-exposure prophylaxis and people will be taking it once a day for life because they know that that is the life they've chosen. In fact, that is in fact
wear condom, that's all. And just wear condom. Just wear condom.
But if the person says that they don't wear condom, that's the person. You can't force it on the person. Way is that you need to try and approve some things like that for people who are in that business, because you've tried fighting commercial sex workers for a very long time. It's not working. So just try and cut down the healthcare bills for public health sake, because in the end, if any of them gets HIV, they'll end up giving it to some man who has a family whose wife has made him angry, so decided to pass bicycle or La Paz or something before going home.
That person should just sleep
before going home. And then in the end, the man can die and the children will become a public burden. So when we all get into public positions one day, have to, push for those things, those preventive things for people who are in that line of business. And also, if you can't stop the whole commercial sex work activity or whatnot, make it expensive for them. You let them pay a tax. It's called sin tax, SIN. Into the bonina tax. If you go to many countries, people pay sin. The system has to change. People pay sin tax. If you go to Netherlands and whatnot, you have brothels and places where you have commercial sex workers there, and it's registered. And every young lady who comes in there to work there is tested, gets regular HIV checks every 3 months. And then whoever is running that business pays tax to the government. So you try and make it expensive, and at the same time you regulate it. If you can't beat them, you have to join them. You join them by regulating the service and making them pay sin tax, so that you use the tax to rather develop the country and set up.
They will transfer the tax on their client. They will put the tax on the client.
Of course, but who do you expect to pay the tax? Everybody pays the tax. It's a sin tax. So you, the clients, you are also going to commit sin. So you also need to pay the tax. So if they are charging you 500 cedis, condom, 1,000 Ghana, raw, then they have to put a levy on that, 10%, 10% tax on that. See, this
Ghana cedis condom.
listen, these are some of the things that we can do to develop. The same thing goes for fighting cardiovascular diseases and all that. You need to put taxes on this sugary drinks and those junk food and things. It's called syntax. People are doing it outside, and at least it's preventing some people from buying unnecessarily, because it should be expensive. But if you come to Ghana, Rush energy drink is rather very cheap, and then your Blue Skies is rather expensive. It's not supposed to be like that. If your Blue Skies decides to sell at 10 cedis, your Rush energy drink should be selling at 12 cedis or 15 cedis. If you buy it, that is your punishment for buying it. That's the syntax. Because in the end, if you take the Rush energy drink and you don't sleep and you are driving, and then you get an RTA, and you kill someone, there's a future leader, or you kill someone who is already contributing his quota, you've deprived the state of, a lot of development. So one day when we get into political position, I know I'll meet a lot of you guys there. This is what we should be fighting.
Yeah, you're already there.
All right. Enjoy your evening.
Remember us. Okay.
So we'll have a class on Friday, and then over the weekend I'll give you some topics for emergency medicine. I'll try and send it to the class reps. It's just a revision basically, and we can actually finish. Yes,
slides. We've not gotten all.
You haven't received slides.
It's making learning difficult.
I don't think you said questions on the ones that we've not received.
Yes.
Don't be tired.
Don't worry. Thanks for informing me. So don't worry. If you don't receive any slide by the close of today, you won't get any question on that. Okay.
Thank you.
You're there. You should have asked it.
What do we do? The time is near.
So enjoy your evening, and make sure
your bundle.
You
look
at your WhatsApps tonight. I'll flood it. Good night.
Your bundle is going off. Your bundle is going off.
All right. See you on Friday. Okay.
Bye. Bye. Only rush.